So right now we're going to be discussing the manifestations of right-sided issues versus left-sided issues in regards to the heart. So let's keep in mind that the structures that we have on the right side include your tricuspid valve and your pulmonary semilunar valve, and these are valves that open and close and permit blood to pass on through when the ventricles contract, okay, or when the atrius contract and allow to push blood down to the ventricles. And then on the left side, we have our bicuspid or mitral valve, and we have our aortic semilunar valve. So again, I keep emphasizing this whole idea that you guys got to remember which structures are on the left and which structures are on the right side of the heart. To begin, let's start discussing right-sided heart failure, right? So when we talk about right-sided heart failure, keep in mind that the R for right side, it looks like a B. So remember that it backs up into the body. At this particular point, we can start listing all the potential clinical manifestations that a person with right-sided heart failure is going to be manifesting based on the idea that if the right side is not pumping blood to where it's supposed to, meaning towards the lungs, then the blood eventually starts backing up. Initially, it starts backing up this way, down towards the inferior portion of the body. We discussed this as being the inferior vena cava. And so keep in mind that the inferior vena cava receives blood from a variety of tissues. And primarily we're talking about our legs, okay? Our little bootleg legs right here. So you're gonna start developing peripheral edema. To be specific, it's gonna be dependent. And dependent edema is describing the fluid collection wherever gravity is pulling fluids towards. So it's going to be at the ankles primarily, but you could also have some in your sacrum and different areas like that. Keep in mind that the inferior vena cava also receives blood from what organ? We discussed the liver. So since the liver is receiving blood from the inferior vena cava, since the inferior vena cava is receiving blood from the liver, eventually it's going to start backing up towards the liver as well. And this is when you develop things like hepatomegaly. And so hepatomegaly is enlargement of the liver because the blood's backing up, and eventually the liver is also collecting fluid, all the blood from the intestines. We're talking about the esophageal veins, we're talking about the gastric veins, the intestinal veins. All of those veins eventually merge and they confer all of their blood to the hepatic portal vein. And because of that, since the liver is being backed up with blood, you develop hepatomegaly. Well, the hepatic portal vein also becomes congested. You develop hepatic portal hypertension. So hepatic portal hypertension. And so this is going to enlarge the right upper quadrant as well. It's going to congest all the veins that are delivering blood to the liver from the entire GI tract, including from the esophageal veins all the way down to the rectal veins and everything in between. So this is why people with right-sided heart failure, they start to develop anorexia. They start to develop a lot of GI issues because the blood is backing up into the intestinal tract, into the GI tract. And eventually, when it gets severe enough, the symptoms will manifest hepatic issues like liver cirrhosis. The patient may develop esophageal varices. So keep in mind that when it comes to the backing up of fluid from the inferior vena cava and below, this is where the general fluid is going to be collected, okay? When we're talking about the superior vena cava, okay, the blood starts working that way, towards the top. This is where you get manifestations that include jugular vein distension. You guys probably recognize it as JVD. That's because the blood eventually backs up into the jugular veins, which usually drain to the superior vena cava, but in this case, it's backing up towards the jugular veins. And then all the blood vessels that you have draining the entire thoracic cavity, they eventually go back to the superior vena cava. And this is where we get the manifestation of central venous pressure. Your CVP, your central venous pressure, goes up. It's important to keep in mind that when the CVP is 10 millimeters per mercury, like we measure the same units that we use to measure blood pressure, if it's 10 or more, when the CVP is 10 or more, that's classified as heart failure. So keep in mind that we usually have little catheters that go underneath the subclavian into the subclavian vein, and that's how we monitor the CVP levels. All of these are indications that the right side is failing. So whether it's right ventricular failure, or whether you have issues with the tricuspid valve, the AV valve on the right side, whether it's, regardless as to whether it's stenosis or if it's insufficiency, the patient's going to manifest right-sided heart failure issues because the tricuspid valve and the pulmonary semilunar valve are on the right side. So eventually the blood, as it passes through, it's going to start collecting and start backing up into the superior vena cava. That includes the elements that we're going to normally manifest and notice in right-sided heart failure. When it comes to the left side, it's a little bit different. We discussed left-sided heart failure, L for lungs. All of your clinical manifestations are going to be associated with the blood backing up into the lungs. Let me explain. If you have left ventricular failure, what ends up happening is, since the pulmonary veins are bringing blood from the lungs to the left atrium, like we discussed before, eventually when the left ventricle starts failing, it can't keep up with the demand. As blood's coming in this way, and filling up the left ventricle with blood, since the left ventricle can't pump efficiently enough, it will not be able to put all the blood to the aortic semilunar valve. And so it starts backing up eventually to the lungs. So keep in mind that all your left ventricular failure manifestations are going to be associated with regurgitation of fluid going back to the lungs. And so let's talk about some of those things. When it comes to left-sided heart failure, or if you have mitral valve stenosis or insufficiency, or if you have aortic semilunar valve stenosis or insufficiency, eventually that blood will start backing up into the lungs. L, left-sided heart failure for lungs. And so we're going to have things like hemoptysis, which is coughing up blood. We're going to have shortness of breath, dyspnea, paroxysmal nocturnal dyspnea. Now, this is something you guys really have to pay close attention to in regards to its manifestations. When somebody develops heart failure, it doesn't just develop from one day to the next. Little by little, the ventricles become fatigued due to the cardiac demand that's placed on it, and eventually the heart ventricles fail. So, this paroxysmal nocturnal dyspnea describes an event that the patient feels when they're sleeping, when they're laying down, and the heart, the ventricles, as they're pumping, the left one begins to fail abruptly. Okay? And so what ends up happening is the blood starts rushing back to the lungs. And so the patient feels like they're drowning while they're sleeping. That's your paroxysmal nocturnal dyspnea. Your patient will describe a sensation of drowning while they're sleeping, and it awakens them. This is some subjective data that's needed. It's going to need to be taken down so you can add to the collection of data so you can start developing a care plan for this patient. You have to keep in mind that all of these clinical manifestations are explaining to you as a nurse what's going on with the patient, so we can start describing some type of implementation so we can better help the patient with their manifestations. So continuing with left-sided heart failure, we discussed hemoptysis, shortness of breath, dyspnea, paroxysmal nocturnal dyspnea. The patient's saturation is going to be dropping as well. At the same time, the patient's going to have a difficult time laying flat and breathing adequately. We call that orthopnea. Notice that we can start memorizing all of these individual clinical manifestations, or we can think of the concept, and the concept dictates that when you have left-sided heart failure, all of your clinical manifestations are going to be based on left or lung issues. So keep in mind that left-sided heart failure, regardless as to whether it's the left ventricle or the left structures, it's going to back up into the lung, and it's going to give you these clinical manifestations. Generally speaking, when a patient has heart failure, regardless as to whether it's left or right-sided heart failure, the patient's going to be needing some medications, correct? So at this point, we have to start discussing, well, what's happening with the patient? The first thing that we notice is that they're retaining a lot of fluid. So what type of medications can we give that will excrete the excess fluid inside the body? We can start talking about diuretics. Okay. And to name a few, we can talk about hydrochlorothiazide. We can talk about furosemide. And we can even discuss diuretics such as aldactone or spironolactone. So keep in mind that hydrochlorothiazide and furosemide are medications that deplete potassium. So you can develop hypokalemia when it comes to giving hydrochlorothiazide and Lasix furosemide. Or when you give aldactone, this is a potassium sparing diuretic. And these type of diuretics, they spare potassium. They excrete the fluid, but they keep the electrolytes. Keep in mind that that medication is making your kidneys do something that it normally does not do. Let me explain. When you give hydrochlorothiazide or furosemide, these medications block the mechanism of excretion of fluids and electrolytes, which usually occurs somewhere around the loop of Henle or furthermore with the hydrochlorothiazide. But these medications are blocking both of those mechanisms. They're doing both at the same time, something that the kidneys normally do. If they excrete fluids, electrolytes go with it. If they retain fluids, they also retain fluids with them. But when you give an aldactone, spironolactone, this medication forces your kidneys to excrete the fluid, but it retains the potassium, the electrolyte. That makes your kidneys work a little bit more efficiently or puts more strain on your kidneys. And that's going to cause us to have to keep an eye on the kidney function, because the kidney function may suffer for it. And so we must monitor it to ensure that the patient's kidney function does not suffer for it. So keep in mind that hydrochlorothiazide, furosemide, potassium depletion, you may develop hypokalemia. Aldactone is going to potentially cause hyperkalemia or elevated potassium levels. And make sure you guys know that your normal potassium level is 3.5 to 5.0. Now, these medications take care of the excessive fluids, but that's not going to address the main issue that the ventricles are perhaps failing. At that point, we want to give the favorite drug to give, which we know as digoxin. Digoxin is a very important drug because what the heart normally does when it's going to pump stronger, it recoils and then the contraction force is greater. Unfortunately, right now for this patient with heart failure, if they have heart failure, you don't want to expend so much energy on the contraction ability. So what we end up doing is we give medications like digoxin that help increase the contraction. It maximizes cardiac output without the recoil, which decreases the workload on the heart. And that's what digoxin does. Keep in mind that when you give digoxin, digoxin must utilize potassium in order for it to be able to enter the cell. So we've already discussed when someone's suffering from heart failure, it can be not assumed, but we understand the patient's also going to be on other medications like diuretics. And if we understand that digoxin must have potassium in its therapeutic values to work well, if someone's taking Lasix or hydrochlorothiazide, now you may develop hypokalemia. The potassium will not be able to get into the cell due to that potassium level, and you may develop Digoxin toxicity. To elaborate a little bit more on that, think of this cell right here as being the heart cell. Okay, this is the cardiomyocyte. Little line so we can know they're striated. And so we know that we need digoxin to get inside the cell so it can help it contract more efficiently without expending too much energy. So if our potassium is between 3.5 and 5.0, then we have enough potassium to get that digoxin inside the cell, as shown here. But what happens when we're taking hydrochlorothiazide, furosemide, understanding that it may deplete potassium? The patient may develop hypokalemia. And if the patient develops hypokalemia, they're still taking their digoxin as they're taking their Lasix because they're suffering from heart failure, right? Now you have all this D, you have all this digoxin, but you don't have enough potassium to help push the digoxin inside the cell. So the digoxin accumulates in the bloodstream, and now you've developed digoxin toxicity. Digoxin Toxicity. And the clinical manifestations of any medication, when it's in abundance in the bloodstream, it starts irritating a lot of the tissues, a lot of the nerves. So people generally have nausea, vomiting, and sometimes visual disturbances. The patient will verbalize to you that they see yellow pigmentations in their visual field. Not to say that their eyes are jaundiced or they're yellow, no. The patient will see yellow pigmentations in their visual field, and that usually indicates that the patient's suffering from digoxin toxicity. And at that point, we want to give the antagonist, which is known as Digibind or Immune Fab. Immune F-A-B. These are the medications, the same one, that you're going to be giving when somebody starts manifesting digoxin toxicity. And generally speaking, digoxin toxicity levels are usually above 2.0. And that signifies that the patient's developing digoxin toxicity. The clinical manifestations are going to be emphasized more so when that dig level rises to 2.5 or more. So keep in mind, guys, that when you're discussing all these issues, this should be your foundation as a nurse. This is what you should know. This is what you should be studying for. However, when we talk about nursing implications, patient teaching, when we talk about nursing interventions, well, let's tackle some of these elements real quick. If we talk about the patients retaining excessive fluids, you understand that we have to find out where those fluids are being retained so we can help move them back to the heart so they can pump them out to the systems where they're supposed to be, right? We understand that the patient's retaining fluids in the tissues. So if the patient has any type of peripheral edema, dependent edema in the legs, well, we elevate those extremities. And we elevate them so it can help with venous return. If the patient has any type of central venous pressure, jugular vein distension, because of stenosis insufficiency or right-sided heart failure, you understand they're going to have excessive fluids. The patient may be placed on what? Fluid retention. What if the patient has maximized their daily intake? Generally speaking, fluid intake is restricted when patients have retention of fluid, and the doctor will order a restriction that includes whatever the urine output is, and on top of that, you add about 600 to 700 mLs, and that's going to be their total intake for the 24-hour period. So if the doctor has restricted their fluids, so let's say 1,500 mLs in a 24-hour period, and it's been 22 hours, and they've consumed the entire fluid supply, meaning the whole 1,500 mLs that I just stipulated that the patient may be on restrictions for. If they're still thirsty, what do we give them? Well, we can't give them ice chips, not anymore. We can give them ice chips while they can still have fluids because the ice chips are cold. They're small, they can chew on them, and it kind of refreshes the mouth and it lasts a little bit longer. However, now that they've met their max intake of fluid, the 1,500 mLs that I'm discussing, now the patient needs to have their oral cavity to become moist. So we can give candy, sugarless hard candy. We can provide oral care. Those are the elements that we're going to be thinking about as your role as a nurse. What are you going to do? Something as simple as the mouth is dry, the patient's still thirsty. At the facilities, I understand sometimes they do things a little bit different. We call that real world things. We're discussing theoretical concepts. We're discussing ATI. We're discussing NCLEX question concepts that we have to abide by in these ideal situations that the NCLEX and ATI are going to be presenting in front of you. Continuing with heart failure, guys, we talk about left-sided heart failure. Well, what position would this patient with left-sided heart failure be placed on? Well, we want to provide maximum lung expansion, and the book discusses that the patient should be at least semi-phallus position. But we understand that when they have left-sided heart failure and they have pulmonary edema now, what are you going to auscultate? What type of adventitious breath sounds are you guys going to be expecting? Crackles. And if somebody has crackles, the goal is to get that fluid as low as possible in the volume of the lungs so there can be better gas exchange. So you want to place the head of the bed elevated whenever they have any of these issues. The patient that has impaired gas exchange, what this patient will have, meaning they're not getting rid of carbon dioxide and they're not bringing in enough oxygen, we're going to provide them with the teaching of pursed lip breathing. Pursed lip breathing because that maximizes oxygen intake and it maximizes the elimination of carbon dioxide. So keep in mind that you have to understand these concepts to be able to distinguish what your nursing intervention is going to be for your patient. We don't know what the NCLEX is going to ask you. We don't know what ATI is going to ask you. However, if you have a solid foundation, you can muster up the cognition that's necessitated for you to select the correct answer. Sometimes you don't have to know the correct answer. You just have to know what the incorrect answer would be. For instance, if you get a question that has that the patient with right-sided heart failure has dependent edema, and you get a few options as to how you would position those extremities. Well, the veins normally bring blood back to the heart. So you can't place those legs in a dependent position because that's going to exacerbate the issue with the legs being unable to bring back the blood to the heart. So you can at least eliminate that particular answer. It's important for you guys to understand that no one knows everything. I don't know everything. I haven't met anyone that does. But you guys have to have a solid foundation. Your solid foundation is something that's going to help you eliminate improper answers and select the best possible answer. Always consider the questions when they ask you for initial interventions. Initial interventions are always geared as less intrusive, less invasive, generally speaking, non-medicated tactics that we utilize to help promote patient comfort. And so when we start thinking about heart failure, folks, a couple of elements that you really want to emphasize. Fluid retention. Where's the failure at? Or where's the issue at? Left, because if it's left issues, it backs up into the lungs. If it's right issues, it backs up into the body. We discussed the medications. We discussed diuretics. We discussed the digoxin. We discussed the antagonists. We discussed normal potassium levels. Those are all your foundations, and that's the type of information that you have to memorize in order for you guys to have the tools to select the best answer. I hope that helped out.